All right, I'd like to present our case for this morning. First of all, good morning, everyone. We need to address the
Morning.
urgent readmission of Mrs. Jamie Carter. If you remember, she is a 68-year-old female recently discharged after hospitalization for exacerbation of congestive heart failure. She lives alone and has a history of hypertension and type 2 diabetes. Mrs. Carter struggles with medication adherence and dietary restrictions. She was prescribed new CHF medications and instructed to follow the MODS guidelines for self-care at home. In addition to this, Ms. Carter has a psychiatric background. She has a history of psychoaffective disorder. She takes Invega, she has been prescribed Invega. However, she is non-compliant with that medication as well. Just before this admission, Ms. Carter was found walking alone around midnight, very disoriented. EMS brought her in. This is now her third CHF-related readmission in 2 weeks, well beyond the CMS benchmark of having a less than 20 to 30-day readmission. It raises serious questions, both clinical and ethical.
I actually remember this case. I reviewed her case this morning, Miss Carter's case this morning. I remember she was stabilized. We started her on Lasix, on Coreg, and continued the Invega for the schizoaffective disorder. I actually remember reviewing the MODS guidelines with her, and after thinking about it, I don't think that she could explain it back. She has no caregiver, minimal insight, and a clear executive dysfunction. You know what? I think this goes beyond noncompliance. I think it's actually, yeah, a cognitive and a psychiatric barrier.
Debbie, I appreciate that, but from a discharge planning standpoint, she should have never gone home in the first place. According to the NCQA and CMS discharge standards, patients with cognitive impairment and psychiatric comorbidities should receive enhanced transitional care, including home health, behavioral follow-up, or transitional housing. None of that happened. As you said, she lives alone. That's unsafe. She's wandering the streets. I mean, how did we discharge her? How did
You
it
know what?
happen?
I submitted a referral for home health and for the psych follow-up, but nobody got back to me. I didn't get a confirmation right away. I'm managing 15 discharges a day, and this can definitely not fall on my lap, not all on me.
Debbie, I understand where you're coming from, but this is a systems failure, not just yours. Here's the bottom line, though. We discharged a severely impaired patient with poor health literacy into the community without any monitoring. No home health, no follow-up, nothing. That's a violation of NAA ethical standards for non-maleficence and beneficence. We are liable if harm comes to her.
Okay, guys, let's focus on solutions. We see that there are lots of issues, lots of problems. Evidence shows that teach-back education reduces CHF readmission by up to 30%. But that requires repetition and support. Mrs. Carter needs cognitive, adapted education and interdisciplinary coordination. She couldn't even recall her medication schedule yesterday.
Okay, I'm going to escalate this to the Adult Protective Services for possible emergency placement. We may need to consider a psychiatric skilled facility or PACT. That's the program for assertive community treatment. She doesn't qualify for inpatient psych, but she is clearly unable to live independently, and this is a matter that needs to be taken care of immediately.
You know what? I'll contact psychiatry today for reassessment and coordinate with you, Samantha, on APS referral. I also want to request a neural psych consult. We may be dealing with early cognitive decline, not just a psych issue.
Okay.
Yes, that's a good point. We also need to document our interventions thoroughly. CMS audits readmission patterns, and we need to make sure that we keep track of these and get on top of them when we can. And look for quality improvement plans for patients such as this in the future. I'll work with our compliance department to review high-risk discharge protocol gaps.
Thank you all. I'll revise our MODS materials for low literacy and psychiatric populations and coordinate with the nurse case manager for a 48-hour follow-up call. Research supports early follow-up as critical intervention.
Okay, I can schedule a care conference with community, mental health, home health, and APS once we secure a temporary placement.
Okay. To be clear, do we all agree that sending Mrs. Carter home again would violate both clinical best practice and our ethical duty?
Yes.
Yes.
Yes. Then we move forward as one team. Let's prioritize safety, dignity, and wraparound care. Thank you all for advocating for our most vulnerable patients.
Thank you.
Thank you.
Thank you.
Have
You.